Eh? Yeah, so we'll start with the first speaker. Is Dr. Chris Matthew Koshi. He'll be talking on a comparative study of corneal endothelial cell count in diabetics and non-diabetics.
Good afternoon. Today I am going to present a paper on the topic a comparative study of corneal endothelial cell count in diabetics and non-diabetics in a tertiary care hospital in North Kerala. Coming to the introduction and rationale of the study, diabetes may cause corneal endothelial morphological alterations in average cell size, coefficient of variation, corneal endothelial cell density, and hexagonality. Keratopathy is a significant consequence of diabetes mellitus. Therefore, changes in corneal findings are increased along with progression of diabetic retinopathy. Diabetes mellitus can lead to ocular problems that include diabetic retinopathy, corneal endothelial cell change, superficial punctate keratitis, recurrent corneal erosion, and persistent epithelial abnormalities. Aim is to study corneal endothelial cell count in type 2 diabetes mellitus patient and non-diabetic individuals. Objective is to assess morphological changes in corneal endothelium in type 2 diabetes mellitus patients. Methodology: study design is a hospital-based comparative cross-sectional study. Study setting is among already diagnosed type 2 DM patients and non-diabetic individuals attending ophthalmology OPD of a tertiary care hospital in North Kerala. Study duration is 1 year after obtaining ethical clearance. Sampling was done by convenient sampling. Sample size was 92 for each group, which was obtained from a previous study by Ahmad et al. Inclusion criteria for cases are patients between ages of 18 and 70 years with already diagnosed type 2 diabetes mellitus, and inclusion criteria for controls are healthy individuals without type 2 diabetes mellitus between age of 18 and 17 years coming for health checkup are selected. Exclusion criteria are those wearing contact lens user, history of dry eye disease, patient who underwent any procedure like laser, intravitreal injection or previous ocular surgeries, anterior segment disease or any corneal disease, type 1 diabetes, history of glaucoma, ocular trauma history, and continuous use of topical medication for any ocular disease. Method of data collection: it was collected from both eyes of the patient and instruments of the study. This is an image of the corneal endothelial cell count by which a non-contact specular microscopy is used, and along with this we used a slit lamp biomicroscopy and indirect ophthalmoscopy with 20 diopter lens, and a comprehensive ocular examination was performed on all subjects. The corneal endothelial parameters are recorded, and coming to the results. There are 27% had diabetes within the duration of 5 to 9 years, and for the less than 5 years it is about 46%, and 68 had no systemic complications of diabetes, 13 had history of coronary artery disease, and 7 had chronic kidney disease, and 4 had history of diabetic foot. On comparing corneal morphological parameters in diabetic group by using Pearson correlation, it was observed that corneal endothelial cell density is having positive correlation with hexagonality and negative correlation with average cell size and coefficient of variation, which is seen in that table. And it also shows that the mean corneal endothelial cell density decreased and the mean average cell size increased with increase in duration of diabetes and severity of diabetic retinopathy. These observations were considered statistically significant as p-value obtained is less than 0.05, and the best corrected visual acuity, corneal endothelial cell density, average cell size, coefficient of variation, and hexagonality were assessed, and results showed that the mean corneal endothelial cell density and mean hexagonality in the diabetic group is decreased, and the mean average cell size and mean coefficient of variation in the diabetic group is increased when compared to the non-diabetic group. This signifies that there is pleomorphism and polymegathism in the diabetic group. Coming to the discussion and conclusion, in diabetic patients there is decreased corneal endothelial cell density, increased average cell size, increased coefficient of variation, that is polymegathism, and decreased hexagonality, that is pleomorphism, which is not associated with age-matched non-diabetic individuals. The results of this investigation corroborate previous notions of reduced endothelial cell density among participants with type 2 diabetes mellitus compared to non-diabetic persons. These changes correlate with diabetic age and retinopathy severity, and presence of microscopic changes in diabetic corneas might cause more chances of corneal endothelial decompensation during cataract surgery, which shows importance of preoperative corneal endothelial assessment and judicious use of ocular viscoelastic devices at the time of cataract surgery in the diabetic patients. Therefore, people should be aware of various risk factors associated with development of diabetic retinopathy, and this signifies importance of early ophthalmological screening programs and patient education to diabetic patients to avoid preventable blindness caused due to diabetes associated retinopathy and keratopathy. These are my references. Thank you.
Any correlation was there with the HbA1c and all these things?
Yes, HbA1c also, as the Sugars value is uncontrolled, the HbA1c values are increased, and it shows that the corneal endothelial cell density is also decreased. It was also compared.
What's your advice now? Because you have compared now.
So we have to do a regular screening about the diabetic retinopathy status and also correlate with
You have studied about hexagonal, that mainly corneal
endothelial cell density.
By studying endothelial density, what are you going to achieve now?
So if you are planning any cataract surgery, we can take adequate precautions that the corneal endothelium is protected. So further damage and chance of further decompensation are reduced.
Thanks.
Thank you, sir.
Okay. Next, we have Dr. Choimadatil Fatima Salaha, and she'll be presenting posterior segment changes in myopia, a cross-sectional study at a tertiary care center.
Good afternoon. My topic is posterior segment changes in myopia, a cross-sectional study at a tertiary care center in North Kerala. The number of people affected by myopia is now increasing around the world and is projected to affect 50% of the world population by 2050. The prevalence of myopia is more in some geographic areas and ethnic groups than others. Posterior segment changes are the most common cause of vision loss in myopic patients. Cases of myopia are growing in number, and there is a need to extensively study the different entities of myopia in Indian settings. Objectives of the study are to evaluate the posterior segment changes in myopia, to correlate the degree of myopia and the incidence of posterior segment changes of myopia, to correlate the posterior segment changes of myopia with axial length. Methodology: it was a hospital-based observational cross-sectional study conducted at the outpatient department at a tertiary care center in North Kerala. Study population was patients attending the outpatient clinic of Department of Ophthalmology for a study period of 1 year. It was convenient sampling, and the sample size was calculated to be 92. Inclusion criteria for the study: all patients with myopic refractive error and age more than 5 years. Exclusion criteria: patients with index myopia as in senile cataract were excluded. Patients with congenital anomalies like microphthalmos, aniridia, megalocornea. Acquired causes of myopia such as post-traumatic and drug-induced. Patients diagnosed with other retinal pathologies were also excluded. Subjects who are not cooperative for performing visual acuity testing, like very young children or mental retarded, and patients who have undergone refractory surgeries or any ocular surgeries in the past. Data collection: information regarding age, gender, occupation, family history, duration of spectacle usage, frequency of spectacle change was collected using an interview and with a performer. Refraction was done and subjective correction given for all patients. Complete ocular examination was done, including dilated fundus examination. Axial length measurement was measured using A-scan by contact technique. Coming to the results. From the study, it was observed that the most common age group was 15 to 30 years, which comprises a 65% of the study population. And it was found to be more prevalent in females, 63%. And a majority of the population gave a positive family history of myopia. Comparing the other variables like duration of spectacle contact use, the mean was found to be 11 years, and time since last change of spectacles or contact lens, it was a mean of around 1.37 years. And spherical equivalent in right eye and left eye was found to be minus 4.19 and minus 3.43 respectively. While comparing the best corrected visual acuity in different degrees of myopia, it was found that 82% of the study population improved with 266 vision in mild myopia group, and vision less than 624 were most commonly seen in the high myopia study. And comparing the axial length, the average axial length in mild myopia was 23.7 and moderate was 25.32, and in the high myopia group, the average axial length was 27.48 in the study. And now comparing the posterior segment changes in myopia, the most common changes observed were the myopic large disc and the retinal tessellation, followed by peripapillary atrophy and myopic crescent. And other changes like lattice degeneration, retinal hole, and posterior vitreous detachment are also prevalent. When we see the most common change, that is a myopic disc change, we can see it is more common in the high myopia group. And also retinal tessellations were also higher in the high myopia group. When we compare the peripheral retinal changes, lattice degeneration was commonly seen in the moderate and high myopia group almost equally, and other degenerations like snail track, retinal tear, retinal hole, and retinal detachment were more in the high myopia group. Coming to discussion, increased prevalence of myopia was found in females of around 62% in the study, and another study, similar study in South India, showed a 57% prevalence of myopia in females. There's a positive relationship with family history of myopia in 62% of the participants. The mean duration of time since last change of spectacles was 1.37 years. We can also infer that adults tend to lag on regular follow-ups. The mean axial length increases with increase in dioptric power of myopia. The most common posterior segment changes found in this study are myopic large disc in 55.4% and in retinal tessellation 51%. In contrast to a finding of 22.8% of lattice degeneration among 184 eyes, few other studies show slightly higher prevalence. Overall, the study shows a strong and significant correlation between the existence of different posterior segment changes and the degree of myopia, with higher degrees of myopia being more frequently linked to these conditions. These are my references. Thank you.
So you have not shown any single picture of posterior segment findings. The problem is here. You have not shown anything, no, about posterior segment lattice and all. You have not shown pictures in your study. You have done study, no, because you have calculated all these things.
Yes,
so naturally, you're supposed to show the pictures. You have not shown.
Sir, I have the pictures. I haven't included.
No. This is a competitive exam, like competitive. You have to show all those things.
Yes.
Then the slides management, no, you have put all the sentences in something of so many lines in a single slide. It's very difficult to visualize. Yes. Something is crowding. So naturally, you'll have difficulty in reading also.
Yes, sir.
Number 3 have shown posterior segment findings in tessellation of myopia. But tessellation can be seen in normal persons also.
Yes,
how can you say that only in myopic posterior? It's not because of myopia. So tessellation can occur because of pigments in the retina, pigment epithelium less or more in choroid. That's all. It is not because of I think myopia. Okay.
Yes, sir.
There are some other flaws. Okay.
In which group will you get the retinal detachment? Simple, medium, like high myopia. In which group?
In with peripheral retinal degenerations.
No. Retinal detachment. Common, very common in which group?
High myopia group. Moderate and high myopia group. Thanks.
Next, we have Dr. Renu John, and they'll be talking about clinical epidemiological profile and visual outcome of viral keratitis.
So, good afternoon. My topic: clinical epidemiological profile and visual outcome of viral keratitis in a tertiary care center in Kerala. So, coming to introduction. Viral keratitis, the inflammation of cornea mostly caused by viral etiology, loss of vision secondary to cornea scarring and surface irregularity. When left untreated, they can further cause cornea perforation leading to loss of eye. Herpes simplex virus keratitis is leading cause of monocular infectious blindness in developed countries due to stromal opacification with a higher recurrence rate. Herpes zoster keratitis is the other common cause for viral keratitis and occur due to involvement of trigeminal nerve. Adenovirus subtypes 1, 3, 7 and 14 produces pharyngoconjunctive fever, of which about 13% cases develop corneal lesion which are mild and self-limiting. Cytomegalovirus is the other virus getting prominence in the last 2 decades and is known to affect corneal endothelium. Objective of the study is to describe the clinical demographic profile and predisposing factors of viral keratitis in patient attending a tertiary care hospital in Kerala, and to study in the visual and clinical outcome of viral keratitis cases. Methods and methods. Source setting was patient with the viral keratitis attending Department of Ophthalmology. Study design hospital-based prospective cohort study. Study population all consecutive cases of clinically diagnosed viral keratitis patients attending outpatient Department of Ophthalmology. Sampling technique was consecutive sampling. Inclusion criteria are all patients who are clinically diagnosed with viral keratitis attending outpatient Department of Ophthalmology, and exclusion criteria are patients with mixed microbial keratitis and bedridden patients. So sample size and study tools include self-prepared questionnaire including demographic details, systemic comorbidities, predisposing factors, slit lamp biomicroscope for examining cornea, Sneller's chart for measuring visual acuity, fluorescence strips for staining, 0.5% proparacaine drops. Study procedure. Diagnosed cases of viral keratitis was assessed for ocular symptoms, contact lens history, past ocular history, risk factors, systemic disease, and recent or past ocular medications. This is followed by baseline visual acuity examination using Sneller's chart. Both uncorrected and best corrected visual acuity noted. This was followed by a facial examination for any vesicles, facial nerve palsy, and corneal sensation will be checked. Slit lamp examination was done with a focus on eyelid, conjunctiva, cornea, anterior chamber, and intraocular pressure. Fluorescence staining of the cornea was done to reveal the presence of dendritis, superficial punctate keratitis, and geographic ulcers. Both eyes are examined. Follow-up examination was done on 7th day, 1 month, and 3 months. In each follow-up visit, the patient was examined and the findings are noted, including uncorrected visual acuity and best corrected visual acuity using Sneller's chart, cornea sensation, cornea opacity, cornea thinning, and recurrent cheapening. Study analysis by data entered using MSSL and analysis using EPI-Info software. All qualitative data and was expressed in proportion, and all quantitative data will be expressed in means, standard deviation, and 95% of confidence interval. The significance of the result was assessed using appropriate statistical tests of significance. So coming to results, the study involved 88 participants, of whom were over 18 years old, and while 21.6% were aged between 7 and 18 years. The gender distribution was relatively balanced, and 56.8% male and 43.2% female participants. So these are the socio-demographic data we analyzed, and the comorbidities included are diabetes, leprosy, and HIV. Other relevant histories are contact lens use, topical steroid use, minor ocular trauma, fever. The signs and symptoms we included are eye pain, redness, watering, discharge, intolerance of light, blurring of vision, irritation, and foreign body sensation. So this is the graphical plotting of signs and symptoms. Other signs and symptoms considered are dead vesicles, eyelid and adenus, and anterior chamber. In anterior segment, cornea epithelial defects included are superficial keratitis, punctate keratitis, discoid keratitis, geographic keratitis, and other conjunctiva congestion, pupil reaction, intraocular pressure, lens and cornea sensation. So symptoms we checked in 7 days, 1 month, and 3 months with a p-value of 0.01 and signs p-value of less than 0.01. Then the follow-up outcome for study participants were over a 3-month period showed significant improvements in symptoms and signs. Initially, 93.2% of participants experienced symptoms at 7 days, but this decreased to 47.7% at 1 month and further to 9.1% by 3 months. Signs of thinning and opacity also reduced substantially. Visual acuity improved over time with the uncorrected visual acuity of 6 and 2 CCs increasing from 9.1% at 7 days to 45.6% at 3 months. When the best corrective visual acuity for the same range improved from 17.0 to 52.3%. Recurrence rates were low, with only 5.6% experiencing a recurrence of 3 months, including overall positive outcomes and majority of participants. The present study included 88 participants and also we consider this through prior trauma and topical steroid use with the study of Nancy M. Lofty et al. And Kusmesh R. et al. Conclusion: the study demonstrated a significance of clinical epidemiological profile and visual outcomes in wire keratitis. The result indicates that patients with a more severe form of wire keratitis with cornea thinning and opacification develops worse visual outcomes than the patients who are already diagnosed and treated under regular follow-up.
You are told which viral keratitis you have selected, epizoster or something you told, adenovirus?
Adenovirus mostly considered.
No, adenovirus, you are told now pharyngeal fever, that is 3 something you told, 3, 7 or something, that subtypes. What about epidemic keratoconjunctivitis, where you got a subtypes of 8 and 19? You have not mentioned anything about that, because that can produce keratitis rather than your pharyngitis conjunctival fever. Because normally epidemic keratoconjunctivitis caused by 8 and 19, they can produce keratitis. Whereas pharyngeoconjunctival fever, they can produce only conjunctivitis and fever. I don't think they can produce keratitis. That means which keratitis you have included? Only zoster.
Adenovirus and zoster are considered, sir.
Okay, because you are not mentioned about the subtypes and all first. Number 2, you have told sensations decreased. Is it decreased or totally absent? Decreased. Epizoster, normally we get totally absent. See, decreased means compared to other eye, it is decreased. Whereas absent means totally absent. Zoster, you can now normally expect totally absent. And third thing is what? You have not shown any keratitis picture. Always remember, when you present a patient or something, for a competitive exams and all this, you must present pictures to substantiate. You understood? Because you told fluorescent staining, you told branches and all, herpes, something, dendriticals and all. So you should have shown pictures at least. Okay?
Did you measure the IOP contact or non-contact method? You are mentioned in the anti-segment examination, IOP measured. How do you measure it? Is it contact or non-contact? Okay.
Thank you. Do we have Dr. Sinu Elsa James, Dr. Shirin, and Dr. Aisha Sana? Please come inside. Next we have Dr. Athira V. Pillai, and who will be talking on efficacy of cyclosporin eye drops, 0.05% versus 0.09% in dry eyes. Does the strength really matter?
Good afternoon to all. Our study is on efficacy of cyclosporin eye drop. That's two strength, 0.5% versus 0.9% in dry eye disease. Does the strength really matters? As we know, the pathogenesis of dry eye, there is reduced tear film production and increased evaporation led to increased tear film hyperosmolarity and release of inflammatory mediators, which led to surface epithelial damages, and there is reduction of mucin production, and this visual cycle continues to be happen. Then here comes the role of cyclosporin. It's an immunomodulatory agent which causes, the main action is downregulation of the interleukin 2 receptor, and it prevents its gene expression, transcription. So it suppresses the cell mediated immune response. Aim of the study is to compare the two strength of cyclosporin, 0.9% versus 0.5%. Materials and methodology. It's a retrospective study conducted in a tertiary eye institute during 6 months of period. Patients with moderate to severe dry eye were evaluated, and group A include 0.9% group and group B 0 0.05% of group. Then patients underwent dry eye evaluation including lipifo interferometry, Schummer, Tibet and OSD scoring. Those who completed 6 months of treatment were included in the study. After 6 months, again the OSD scores were calculated and analysis done, and p-value of less than 0.5% significant. This is the OSD questionnaire. Here mild, moderate and severe we can classify the patient. And this is a lipifo interferometry. Here we can assess the average lipid layer thickness, and partial blinks were assessed. And here we can see the meibomian gland dropout areas and truncating of the glands. Thus we assess the patients. And the exclusion criteria: patients with the pre-existing ocular surface diseases, those who underwent ocular surgeries in last 6 months, patient treated with oral antibiotics like doxycycline and topical azithromycin eye drops were excluded from our study. Then moving to the result, age distribution is similar between two studies, that is most of them between 61 to 70 years of age group. Gender distribution also similar in A and B group. Meibomian gland loss, which is also similar between the two study group, A and B group, almost similar. Then coming to the OSD score, for group A, the pre-treatment OSD score is 30.1 plus or minus 7.3, which decreases to 20.3 plus or minus 9.2 post-treatment. In group B, the pre-treatment score is 28.2, decreases to 22.6 plus or minus 8.9 post-treatment. In both group, we can see statistically significant improvement before and after the treatment. But the larger decrease in OSD score for group A, that 9.82 points compared to group B, that is 5.53 points, likely account for the significance term versus group interaction observed in ANOVA test. Then moving to the discussion, Rajpur and Metal study the efficacy of cyclosporin eye drops, two strengths 0.5% and 0.9%. There was significantly better improvement with 0.9%, similar to our study. Then Goldberg et al. Study the efficacy of 0.9% group. They saw significant improvement from the baseline, similar to our study. Then Burrard et al. Evaluated the efficacy of three strengths: 0.9%, 0.5% and 0.9%. During this study also 0.09% results are similar, better with the 0.9% group, similar to our study. Then to conclude, in terms of clinical improvement, they have higher percentage of patients with the group B. Group A, 81.8 showed improvement compared to group B, that is 69.1%. Although the difference between two are not statistically significant, it aligns with the trend observed. The OSD score reduction may be clinically relevant. That is, in conclusion, both groups show significant improvement in OSD score after treatment. The treatment applied to group A appears to offer a more pronounced benefit. These are my references. Thank you.
You have 2.05 and 0.09. What do you mean by that?
Two strength of cyclosporin.
No, what is actually there? How many grams or milligrams in how many ml?
Each ml contains 0.09%.
Each ml contains?
And 9.
You are giving 0.05. You are telling, what do you, at least you should know how many milligrams per ml or how many grams in per 100 ml you should know.
9 milligram in 1 ml.
You know, the clue is what? Multiply by 10. So many milligrams per ml. 0.09 multiply by 10, how much?
0.9.
That's all. Understand now? 0.05 means 0.5 milligram per ml.
Okay.
Okay, because you should know this when you are presenting a paper, and moreover you have given only, of course, initially you have got meibomian gland, that opening and all these things, pictures. You have shown from book. Your patient's improvement and all, whatever you have compared, no? Have you got any pictures? You have not shown any pictures.
Sir, that LipiView picture is one of the patient.
You should.
LipiView, that
You have
picture.
shown?
That one picture, sir.
Okay.
This is the right, that.
This side. Okay, these were pictures. No, okay. Thank you.
In a study, the patient have any financial burden? Because this drug is very costly. I
Costly.
think.
And the test, all the tests are not repeated after 6 months.
Okay.
Only the OST scores were calculated. So we cannot do all the tests.
Next is Dr. Aparna RP.
Good afternoon. Today I am going to present our study in which we try to address the question, is pseudoexfoliation syndrome associated with vitreoretinal interface disorders? Pseudoexfoliation is an age-related microfibrillopathy characterized by deposition of protein-like material on the lens, iris and various other ocular and extraocular tissues. And pseudoexfoliation is known to cause anterior segment complications like lens subluxation, glaucoma, non-dilating pupil and weak zonules. And in our study, we tried to analyze whether pseudoexfoliation syndrome is associated with vitreoretinal interface disorders. Ours was a retrospective case control study conducted in a tertiary eye care hospital with study group comprising of patients with pseudoexfoliation and an age-matched control group. We excluded all the patients with non-retinal diseases, high refractive errors, any previous ocular surgeries, any history of the retinal break, uveitis or glaucoma, any advanced cataracts that could affect the quality of imaging, and any collagen tissue disorders or systemic inflammatory diseases. And all the participants has undergone a slit lamp examination, fundus examination and an OCT imaging. And pseudoexfoliation was identified using slit lamp after pharmacological dilatation as grey white flakes on the cornea, pupillary margin or anterior surface of the lens capsule. And OCT imaging done was screened for vitreoretinal interface pathologies, which was defined based on the criteria of the International Vitreomacular Traction Study Group, which epiretinal membrane is defined as the hyperreflective membrane with corrugations along the surface of internal limiting membrane, and the vitreomacular traction as the detached posterior hyalod with attachment at least one point with altered foveal contour and inner retinal layers, and the lamellar macular hall as intraretinal splitting between the outer plexiform and outer nuclei, and full thickness macular hall as a full thickness defect extending from the internal limiting membrane to the retinal pigment epithelium. And the posterior vitreous detachment was classified according to the method of Ukino et al. Into the complete PVD, incomplete PVD and no PVD. And the study group comprised of 91 eyes of 60 patients with pseudoexfoliation and control group 181 eyes of 124 patients without pseudoexfoliation, and the mean age in the pseudoexfoliation was 70 and that in the control was 68. And the rate of the incomplete PVD was 43.9% in the pseudoexfoliation group and 14.36% in the control group. And that of the complete PVD was 5.49 in the pseudoexfoliation group and 3.31 in the control group. And the rate of the posterior vitreous detachment was significantly higher in the pseudoexfoliation group with a p-value of 0.008, which is statistically significant. And the rate of the epiretinal membrane was 29.6% in the pseudoexfoliation group and 16.02 in the control group, and this rate was also statistically significant. And the rate of the vitreomacular traction in the pseudoexfoliation group was 3.29. Even though it was higher compared to the control group, which had only 2.76%, it was not statistically significant. And incidentally, we also found one case each of full thickness macular hall and lamellar macular hall in the control group, but none in the study group. The ischemia, inflammation, collagen tissue defects are known to be related to the pathogenesis of vitreoretinal interface disorders. Similarly, in pseudoexfoliation also, inflammation, oxidative stress, collagen and elastic tissue defects are found. Thus, a common pathophysiological pathway contributory to both can be assumed. In a similar study by Seda Kariaki et al., where they compare the incidence of the posterior vitreous detachment and the epiretinal membrane in unilateral pseudoexfoliative eyes with a contralateral eye and another control group, they found the rates are higher in the pseudoexfoliation group. In another study by McAvey et al., they found that epiretinal membrane are found at a higher rate in pseudoexfoliation patients. And in our study, we analyzed for all the vitreoretinal interface disorders, and we found epiretinal membrane and posterior vitreous detachment are found at a higher rate in pseudoexfoliation group. Coming to the conclusion, the anterior segment complications of the pseudoexfoliation are well established. And in our study, we found epiretinal membrane and posterior vitreous detachment are found at a higher rate in pseudoexfoliation patients. And most of the early vitreoretinal interface disorders are asymptomatic, and therefore early detection and follow-up is very important. This vigilant follow-up of pseudoexfoliation patient for early detection and management of epiretinal membrane and posterior vitreous detachment is essential. And we suggest posterior segment examination of all pseudoexfoliation patients for early detection and management of vitreoretinal interface disorders like epiretinal membrane and posterior vitreous detachment. These are my references. Thank you.
PVD is a normal affair after some years. You have selected only 65 to 70 years old patients. So naturally, I can expect PVD to occur in all these patients. Many patients can have PVD.
Yes.
Normal persons. How can you say it's because of pseudoexfoliation?
So we have compared a age-measured control group, and we found that it was higher in the rate was higher in the pseudoexfoliation patients. We have taken as almost same age group, age-measured control group, and we, even the
PVD you investigated with the OCT only or with even indirect
even with
ophthalmoscopy?
we did both the fundus examination and OCT screening. Both.
Do you know what is PVD?
Detachment of the posterior vitreous from the internal limiting membrane.
Define now, at least.
It is defined as the detachment of the posterior vitreous from the internal limiting membrane.
Which area? Which part of the vitreous is getting detached? Is it only posterior or anterior?
Posterior.
Not anterior.
Yes.
You know, actual definition is any part of vitreous coming out of its attachment posterior to the vitreous base. You know, vitreous base anteriorly we got 4 millimeter. Know that attachment where the vitreous is very firmly attached. So any part we coming from, that's why we can from optic disc, from macula, from vessels, anywhere they can get detached. You are only concentrating on what macula area only, I think.
Yes, sir.
That's the reason. You would have seen all the other areas also supposed to have examined. Okay.
Yes.
Thank you.
PPD, how do you make out with the examination?
We can see as the V string. If it is a complete PVD, we could see as a V string around the optic disc.
Okay.
You should have shown pictures.
Only OCT pictures.
You told her you are done in that ophthalmoscope. The picture should have shown.
Next speaker is Dr. Krishnapriya K, free paper 49.
Good afternoon. My paper presentation is optic nerve toxicity in drug-sensitive TB patients on a daily fixed dose combination anti-TB drugs. For the rational study, RNTCP has begun implementing daily fixed dose combination as a base-based regimen, and we observed an increase in number of ethanobutyl toxicity cases in our OPD following the implementation of FDC regimen. The purpose of the study was to find the incidence and to evaluate the visual function. So the aim to assess the incidence of the optic nerve toxicity in TB patients on a FDC regimen and to describe the pattern and time of onset of optic nerve toxicity from the baseline. And the study design was a prospective study with a sample size of 100 patients. And all patients who are diagnosed as pulmonary and extrapulmonary tuberculosis and who are planning to start daily FDC and who presented to the OPD in a tertiary center for a period of 1 year. And the exclusion criteria, which includes all multi-drug resistance and extensive drug resistant category patients who already received TB drugs, and any media opacitous affecting vision and fundus examination, any history of intraocular or refractive surgery other than cataract, any pre-existing ocular and neurological diseases which affects the vision, and history of any intake of non-ethambutol drugs causing ocular toxicity like phosphodiesterase 5 inhibitors, amiodarone, etc. And first, the examination was performed as a baseline test, that is prior to the start of administration. Then after initiation of ATT, the patients were assessed at every month up to 6 months and 1 month after the stoppage. And each visit best corrected visual acuity using Snell's, color vision by Ishara, slit lamp examination, fundus examination, and retinal nerve fiber layer by OCT and visual field by Humphreys field. And the data collected from each individual was entered in the MS Excel office after coding of variables, and the Wilcoxon test was done with the help of SPSS software. Ethical clearance was attained from IRC and IEC. So coming to the result, the study sample comprised of 200 eyes of 100 patients of newly diagnosed drug-sensitive TB. And the mean age of the study population was 47.6 plus or minus 16.6 years. So the main indication for starting ATT was pulmonary TB, that is 60%. Then 28% was lymph node TB, 3% spinal TB, 4% abdominal TB, and 5% is pleural fluid. So we find that in 4 patients, that is 4%, the visual acuity declined from the baseline during 4th month of follow-up visit. And in color vision, the study revealed that 10 out of 200 eyes, that is 5% showed defective color vision at 4th month, and that was found to be statistically significant. Similarly, the visual field defect was found by 4th month in 8 out of 200 eyes, that is 4%, and that also was found to be statistically significant. But in OCT, we find no significant changes in RF thickness in this study. So, the optic nerve toxicity we find at 4th month, 5 patients developed toxicity which manifested as loss of visual acuity, defective color vision, and visual field defects. So, coming to discussion, in our study, the incidence of optic nerve toxicity was 5%, but various studies like Solo et al., the incidence was found to be 5.31%. Another study by Jitendra et al., it was found to be 9.5%, and a study by Sitao et al., the incidence was 2.24%, and study by Menon et al., the incidence was 19.23%. And a study by Gartby et al., the loss of visual acuity from the baseline was noted at the 2nd month of follow-up. But in our study, the loss of visual acuity was noted from the 4th month of follow-up visit. Similarly, the color vision, defective color vision in our study was about that is 10 eyes. By another study, Gartby et al., the defective vision was found in 16 eyes, and Solom et al., it was found at 10 eyes. Similarly, the visual field defect in our study was found in 10 eyes. In Gartby et al. Study, it was found in 8 eyes, and Solom et al., it was found to be in 10 eyes. So coming to conclusion, the optic nerve toxicity was observed in 5% of the patients on ATT regimen in this study. And average time of presentation of optic nerve toxicity manifestation was 4 months post ATT. And this optic nerve toxicity gets manifested as loss of visual acuity, color vision, or visual field defects. So these are my references. Thank you.
What are the age of the patients who develop these problems, diminished vision? After ATT, you told the range of the age and all, no? Which age patients had a problem of this?
This patient?
No, this 5 patients you told, no? Reduction. What are the ages of those patients?
Out of this 5, 4 patients were at the age of 45 to 50. Say 50.
How do you know that it's because of optic nerve? It can be due to some other cause also, no? The visual reduction.
But during this treatment period?
No, that is okay. What the fixed dose means? What drugs you have given?
Isoniazid, rifampicin, pyrazinamide, and ethamphetamine.
You should know tell the dose also, no? You should have told about the dose of each drug. Then only you can assess. So out of 4, what could be the problem? Which drug may be the reason for these problems?
Mostly ethambutol, but
ethambutol normally the toxic dose, if it is more than 25 milligrams, something like that, no. What is the dose of ethambutol in this fixed drug combinations?
It is 15 mg per kg per
15
15 mg per kg per.
Then do you think it's some reason for that?
Sir?
It could be the reason or not.
Maybe.
How can you say? I am telling you, has developed some other problem for visual reduction. Color vision problem also may be something else different.
But no other cause.
How can you substantiate? I'm asking you, that's all.
Because this dose based on the weight, newly drug regimen is based on the weight also.
Then you should not have given the drug, no, before that weight and all. Better to avoid those drugs rather than, Of course, nice study, but problem is what? You are not able to explain properly, that's the thing. Okay.
Visual acuity, color vision, and field effects. Which one affect first? in toxicity?
In visual acuity, color vision will be first effect, I believe.
Are you sure?
You done fields for these cases. Field effects stored what? Field study. What effects they stored?
I have shown centrocecal and central.
Sure. Taken or
Yes, sir.
Next speaker is Dr. Arya Chandran, free paper 50.
Good afternoon all. Our study is on predicting macular edema recurrence in branch retinal vein occlusion using choroidal thickness. Aim of our study was to analyze the relationship between changes in choroidal thickness and recurrence of macular edema in branch retinal vein occlusion. So, macular edema occurs in 90% of BRVO cases. That is, vascular occlusion or hypoxia increases the level of vascular endothelial growth factor and interleukin 6, causes breakdown of blood retinal barrier by damaging the tight junctions of capillary endothelial cells, causing fluid flux from vessels to tissue. So, the macular edema comes in action. The vascular endothelial growth factor expression in retinal pigment epithelial cells, pericytes and microvascular endothelial cell produces nitric oxide, causes vessel dilatation and increased ocular blood flow, so the choroidal thickness increases. It was a prospective study conducted among 46 patients of 46 treatment-naive BRVO patients with macular edema who underwent at least one dose of intravitreal anti-VEGF injection and followed up for a period of 6 months during a study period of 1 year. And we have analyzed central choroidal thickness, baseline and 1 month after injection by measuring manually at fovea from the hyperreflective Brooks membrane to hyperreflective choroidoscleral interface using OCT Heidelberg Eye Explorer software, and central subfield thickness, which is a circular area of 1 mm diameter centered on the center of the fovea with this macular thickness provided as a quantifiable data on OCT software, which was measured every visit, and CSFT more than 300 micrometer was taken as the criterion for macular edema recurrence. And study population was categorized into Group A and Group B. Group A, patients with macular edema recurrence, and Group B, there is no recurrence of macular edema. That is, after 1 month of intravitreal injection, there is macular edema, and during the follow-up of 6 months, there is no macular edema recurrence. And the Group A was again divided into Group A1 and Group A2. Group A1, there is no complete resolution of macular edema at the end of 1 month of intravitreal injection, and Group A2, there is resolution of macular edema at the end of 1 month of injection, but there is a recurrence of macular edema during the follow-up period of 6 months. Results. About 55% patients show no recurrence of macular edema, and 45% patients show recurrence of macular edema. This graph shows the relationship between baseline central choroidal thickness and macular edema recurrence rate. Patients with the baseline choroidal thickness of 281 to 330 micrometers show high macular edema recurrence rate. This graph shows the relationship between the percentage reduction in choroidal thickness and macular edema recurrence in Group A. Here we can see the patients with less than 6% reduction in choroidal thickness after 1 month of intravitreal injection show high macular edema recurrence rate. This graph shows the relationship between percentage reduction in choroidal thickness and macular edema recurrence rate in Group A1, that is, no resolution of macular edema at the end of 1 month of intravitreal injection. Here also the patients with less than 6% reduction in choroidal thickness after 1 month of intravitreal injection show high macular edema recurrence rate. This graph shows the relationship between percentage reduction in choroidal thickness and macular edema recurrence rate in group A2. That is, no macular edema at the end of 1 month of intravitreal injection, but there is recurrence of macular edema during the follow-up period of 6 months. Here, the patients with 7 to 30%, that is moderate reduction in choroidal thickness after 1 month of intravitreal injection showed high macular edema recurrence rate. Coming to discussion, in our study we have found that higher baseline choroidal thickness and lesser the reduction in central choroidal thickness, there is a high risk of recurrence of macular edema. The similar studies conducted by the Okama et al. Showed baseline central choroidal thickness was significantly thicker in recurring group than the resolved group. And the Visama et al. Showed central choroidal thickness of 300 micrometer was significantly higher in recurrent group compared to response group. And Oshiho et al. Showed macular edema recurrence was lower in cases of treatment-related choroidal thinning. To conclude, even though retinal layers are primarily involved in retinal vein occlusion, choroidal changes have a predictive value in recurrence of macular edema. Most of the patients with branch retinal vein occlusion showed complete resolution of macular edema after first dose of intravitreal injection. So, all the BRVO patients do not require multiple doses of intravitreal injection. And higher the baseline central choroidal thickness and lesser the reduction in central choroidal thickness, there is increased risk of recurrence of macular edema. And moderate reduction in central choroidal thickness increases the chances of recurrence of macular edema following complete resolution of macular edema after 1 month of intravitreal injection. Those patients require frequent follow-up counseling and multiple doses of intravitreal injection. These are my references. Thank you.
Which branch, man? You told BRV or BRO. Which branch is involved?
All the branches.
Nasal branch involved, you can get macular edema.
Supratemporal and infratemporal.
I am asking you all the branches hold.
Sir?
You told all the branches. What about supranasal quadrant if it gets involved?
Yes, sir.
You can get macular edema. Supranasal branch is blocked.
Only with the patients with macular edema.
That means when you are telling macular edema, you should have told which branch was involved. At least should have, because macular drains normally to which vein, know that?
So all the BRVO patients with the macular edema.
No. Macula drains into which part of the vein? Which vein normally?
Sir,
Macula drains into which vein? The tributary from macula enters which vein is more commonly?
Supratemporal.
Then you should have told at least supratemporal vein occlusion or both. Superior and infratemporal. You are telling all the branches,
Most of the patients were supratemporal.
You should mention which branch.
Okay.
BRV means for I can, for fun, we'll tell you why can't be nasal branch.
Okay.
You must be specific.
Okay.
And you have not shown any picture about the macular edema. The fantastic picture and all you have not shown.
Okay.
Understand now?
Yes, sir.
These are all some of the drawbacks. Otherwise, okay. And letters are all very small. That to the references I saw, no?
Okay.
You might have taken with the dissertation page, no?
Yes.
This is your dissertation.
No, sir.
Thesis. Thesis book paper, no? This is dissertation.
Part of the
dissertation. That's why your references you are taken from dissertation book. That's why they are all very small.
No, sir, I want to include in one page. That's why the.
No, that is you can include there. Where in your thesis book. It's a slide, suppose a person standing and sitting last row, you cannot see anything. Always you must include very few lines and slightly, at least 40 size.
Okay, sir.
When you prepare PowerPoint, you must have at least 40 font size.
Okay, sir.
Then only everyone can see.
Okay, sir.
This is a normal, not blaming and all.
Okay.
Just an advice. Hereafter when you prepare PowerPoint, you have to be like this.
Okay.
Thank you.
Okay.
Can you measure choroidal thickness in all OCT machines?
All OCT
Machines.
by man is using the OCT Heidelberg Eye Explorer software. Can measure.
Okay, recently all machines have this technology. Okay.
Thank you, sir.
Next is Dr. Aisha K. Free paper 62.
Good afternoon, all. Our study topic is efficacy of energy titrated collagen cross-linking with riboflavin for sub 400 micron keratoconic corneas. Collagen cross-linking is a minimally invasive procedure in which riboflavin, a photosensitizer, and ultraviolet A light are used to form a strong bonds between the collagen fibrils in the cornea. A minimum corneal thickness of 400 microns is recommended for conventional cross-linking treatment. Conventional method, that is also known as Dresden protocol, in which we do epithelial layers of the corneas are removed and we instill riboflavin solution at every 2 to 5 minutes, and then the UVA light of 370 nanometer wavelength at 3 milliwatts per centimeter square is applied over a period of 30 minutes to increase the formation of cross-linking. And accelerator methods are used in which we use higher intensity of irradiation with a shorter duration. Here comes the sub 400 protocols. In order to prevent the endothelial decompensation due to deeper penetration of the UVA irradiation, these are the various methods evolved so far. We can use hypoosmolar riboflavin solution to cause the artificial swelling of the cornea, or transepithelial collagen cross-linking in which penetration enhancers are used, and contact lens can be placed over the thin corneas, or in M protocol we can give in pulsed or continuous forms of irradiation at alternate basis. And in epithelial island cross-linking method, we keep central cornea as such and we remove the peripheral epithelium only. In our study, what we do is energy titrated C3R. In our study, after the epithelium removal, intraoperative pachymetry value is taken and the ultraviolet irradiation at 9 milliwatts per centimeter square with irradiation time individually adapted to adjust the fluence according to an open source online calculator. Next UVA calculator is done. Aim of our study is to analyze the efficacy of energy titrated corneal collagen cross-linking with riboflavin in sub 400 keratoconic corneas. It is a retrospective study conducted over a period of 4 years in a tertiary eye care center, including the patients of progressive keratoconus with whose central corneal thickness of less than 400 microns, whose BCV, best corrected visual acuity, improving to 6.6 with glasses or contact lens. Kmax values and pachymetry values before and 1 year after the procedure were compared and statistical analysis was done. A p-value of less than 0.05 is taken as significant. This is the app QR code. We can scan the app in our mobile, and here we can enter the pachymetry value of the patient. Then we will get the irradiation time according to the pachymetry value of the patient. Coming to results, 12 patients included, 4 females and 8 males, and mean age of the patients enrolled was 20.6. The mean simulated K value pre-operatively was 58.75 diopter, 1 year post-op was 56.5 diopter. On average, there was a significant flattening in Kmax with a p-value of 0.008. 13 eyes, that is around 86% short flattening of Kmax at 1 year, and 2 eyes, that is 13.3% short stabilization of Kmax value. Average pachymetry values before procedure was 322.06 microns and 1 year after procedure was 335.2 microns. Coming to discussion, in a study conducted by Hafezi F. et al. In 39 eyes, showed keratoconus progression halted with a success rate of 90% at 12 months. In our study, in about 15 eyes, keratoconus progression halted with a success rate of 100% at 12 months. To conclude, energy titrated collagen cross-linking in thin corneas successfully halted the progression of keratoconus in terms of Kmax value. The next UVA calculator provides a safe, inexpensive and user-friendly strategy of performing collagen cross-linking in thin corneas. These are my references. Thank you.
Your tone K value, no? Is it plus or minus? K value.
Plus.
You have shown nothing. Even a small minus was there. That's why it's getting confused.
It was a hyphen.
Hyphen, okay, but you should do plus or minus. You have to put it at least. Okay, fine.
In Indian population, what is the average corneal thickness?
540 to 550 microns.
Next is Dr. Pooja Subru, free paper 72.
Good afternoon. My study is on the topic retinal pigment epithelial changes in pachychoroid disease spectrum. Pachychoroid is considered when in the presence of pachy vessel, subfoveal choroidal thickness exceeds 300 micron or an extrafoveal focus has choroidal thickness more than subfoveal choroidal thickness by 50 microns. So these are various entities: central serous chorioretinopathy, pachychoroid pigment epitheliopathy, polypoidal choroidal vasculopathy, pachychoroid neovasculopathy, peripapillary pachychoroid syndrome, and focal choroidal excavation. The aim of our study is to analyze the morphological changes in RP and choroid in patients belonging to pachychoroid disease spectrum and to analyze the response to anti-VEGF therapy after a follow-up period of 3 months. It is a retrospective study conducted over a period of 1 year. EDA OCT of 100 eyes or 73 patients were analyzed for choroidal thickness and RP changes. Response to anti-VEGF was analyzed with respect to change in subfoveal choroidal thickness and pigment epithelial detachment height. The choroidal thickness is measured under the fovea subfoveal choroidal thickness and below the RP abnormality. The retinal pigment epithelial changes studied are AA sign, various PEDs like flat irregular PED, thumb PED, notch PED, fibrovascular PED, hemorrhagic PED. In our study, CSR was found to be the most common variant, followed by PCV and PPE in about 1/4 of study subjects. The choroidal thickness under the RP abnormality is found to be more than the subfoveal choroidal thickness. Therefore, the choroidal thickness under the RP is more reflective of the disease activity. Serous PD is the most common RP change seen in acute cases of CSR, whereas RP atrophy is seen in chronic cases of CSR. In pachychoroid pigment epitheliopathy, common RP changes are AA sign and flat irregular PED. Here, RP reacts to the underlying choroidal changes without any SRF, subretinal fluid. AA sign was invariably seen in all cases of pachychoroid neovasculopathy associated with flat irregular PED and fibrovascular PED. Polypoidal choroidal vasculopathy is associated with characteristic PED like hemorrhagic PED, thumb PED, and notch PED. Peripapillary pachychoroid syndrome. Here the choroidal thickness is maximum between the optic disc and fovea associated with subretinal fluid and AA sign. This is a graph showing response to anti-VEGF among PCV and PNV patients. The subfoveal choroidal thickness as well as the PED height decreased significantly in the PCV group as compared to PNV, which is indicated by the slope of the graph. Among the intravitreal injection given, aflibercept was found to be better agent, bringing about significant reduction in the parameters assessed. PP is a atrophic variant where there is no subretinal fluid, whereas CSR is the exudative variant associated with subretinal fluid. Both PNV and PCV are neovascular variants where PCV is associated with characteristic PEDs as mentioned. PCV patients showed better response than PNV. That is probably because PCV group is more neovascular disease with exudative component and with high level of vascular endothelial growth factor expression. Therefore, they may respond more to anti-VEGF. In our study, the mean subfoveal choroidal thickness as well as the PED reduced significantly with aflibercept, whereas ranibizumab showed a significant reduction in the subfoveal choroidal thickness only. So, aflibercept is a better agent in bringing about polyp regression. The study conducted by Saito et al. Showed that there was no significant reduction in the subfoveal choroidal thickness with ranibizumab, whereas there was significant reduction in the choroidal thickness with aflibercept at the end of first and 6 months. Study conducted by Hanju et al. Showed that there was significant reduction in choroidal thickness with aflibercept and ranibizumab, but there was no difference among the two injections. To conclude, pachychoroid is a common clinical entity that we see in our day-to-day practice. Identifying the characteristic RP changes is important to diagnose, to plan treatment strategy, and to assess the response to treatment. And regarding the treatment options, intravitreal injection aflibercept is more effective in decreasing the PED height, thereby bringing out polyp regression. So these are my references. Thank you.
What is the usual presentation of pachychoroidal spectrum?
Blurring, there will be blurring of vision will be there.
Do you pick it up by accidentally, or is there any major visual disturbance?
Most cases there may not be major visual disturbances. Many of them are accidentally discovered, but some cases there will be much reduction in the visual acuity.
Okay.
Thank you.
Dr. Sinu Elsa James, free paper 73.
Good afternoon. I'm discussing on tear film abnormalities and ocular surface changes in newly detected hypothyroid patients in a tertiary care center in South Kerala. So the purpose of the study was to assess the ocular surface changes and tear film abnormalities in newly detected hypothyroid patients by comparing the tear function test and ocular surface changes by clinical assessment methods. So introduction is, hypothyroidism refers to a common pathological condition of thyroid hormone deficiency. It is a multifactorial disease which affects the ocular surface and tear film and leads to dry eye. Dry eye in thyroid eye disease is caused by evaporation of tear film due to mechanical factors like increased palpebral fissure height, exophthalmos and lid retraction. So females are more commonly affected, 5:1 ratio. So it was a hospital-based follow-up study. Study was conducted in endocrinology and ophthalmology OPD of Pushpagiri Medical College, Tiruvalla. Study population consists of all newly detected hypothyroid individuals and control subjects and attending the endocrinology and ophthalmology OPD. So sampling size was calculated from the previous study that was conducted by Nidhi Pahari and et al. So according to that, the study population was 25 patients and 25 control groups. So the inclusion criteria included all patients aged between 18 to 50 years with newly detected, that is within 3 months of date of examination, among the hypothyroid patients and control groups of the same age. And all those who are ready to participate in the study, both genders were included. An exclusion criteria, that is post-surgical thyroidectomy and post-radioiodine therapy patients were excluded, and patients who were already on topical medications and prior ocular trauma or surgery, previous refractive error surgeries, contact lens wearers, uveitis, glaucoma patients on topical medications were excluded, and subjects older than 50 years were also excluded because it is a non-risk factor for eye dryness. So the study tools were Hurdle's exophthalmometer, then Snellen's chart, slit lamp, Schirmer strip, fluorescence strip, and serum TSH was analyzed. Then outcome measurement that mainly assessed the tear film breakup time, Schirmer's test, intraocular pressure, and proptosis. So the data was analyzed. Then coming to the results, age group, that is the mean age was 36.86, which was ranging from 22 to 49 years. Out of the 50 participants, most of them belonged to the age group of 31 to 40 years. Then coming to the gender, out of 50 participants, 72% were females. And occupation, most of the patients were belonging to the unskilled workers. And Schirmer's test was done. In Schirmer's 2 test, it was around 68% do not show any dryness, whereas 20% shows moderate dryness, and severe dryness was seen in 12%. Then among the 25 controls, none of the patients showed dryness. Then coming to the TBUT, that is tear film breakup test, that is about 72% were normal, but the tear film breakup time was less in 28%. Among the control, 4% showed dryness, 4% shows abnormal TBUT, and 96% was normal. So then when we compared the Schirmer's 2 test between the newly detected hypothyroid and normal patients, it was not found to be significant. The p-value was greater than 0.05. And when we compared the T-BUT between the newly detected hypothyroid patients and the normal patients, it was found to be significant. Then intraocular pressure and proptosis, when we examined, it was normal in both the control subjects and also in the thyroid patients. And coming to the discussion, it was a hospital-based follow-up study. The mean age was 36.86 and around 44% belonged to the age group of 31 to 40 years and 72% were males, were females. And the mean value of Schirmer's test was around 16.44 and among the controls it was 19.4 and it was not when we compared the but Schirmer's score was found to be reduced in all the hypothyroid patients, and many studies found that TSH receptors seen on the lacrimal gland act as target for autoantibodies in thyroid disease, which results in the lacrimal gland impairment. So the mean value of T-BUT was 9.88 seconds in patients and among the control it was 11.6 seconds, and T-BUT showed a significant relationship when we compared it between the hypothyroid patients and control subjects. So reduced T-BUT was could be due to instability of the tear film, which might occur due to hyperosmolarity of the tear film. So according to the study which was done by Nidhi Paharia, the mean T-BUT was 6.38 plus 2.46 seconds and among the control it was 11.15 plus 2.39. Now coming to the conclusion, in our study we found that Schirmer's test was not a significant test to find the tear film abnormality, though the scores were reduced in the hypothyroid patients compared to normal subjects, but the tear film breakup time can be used for assessing the ocular surface changes. So therefore it is essential to do dry eye evaluation in all hypothyroid patients at the earliest. So the limitations was the impression cytology was a better technique to study the effect of chronic inflammation in the form of loss of goblet cells and squamous metaplasia, which we could not include, and the sample size was small, and long-term follow-up is needed in order to study the effect of thyroid medication, whether it is effective and whether it reduces the this dryness. So that we couldn't do that. That was a drawback. So these were my references. Thank you.
What is the normal value in T Schirmer 2?
Schirmer's 2, that is
normal value. Generally, I am asking you for everyone.
For more than 10.
10. You are told now 15, 14 and 18 and all.
More than 11 to 15 that was taken as.
But you told hypothyroid patient can have a problem of dry eye, you know.
Hypothyroid patients
can have a problem of dry eye.
Yes,
that is mainly, of
in
course,
my study it was found that the hypothyroid patients also showed dryness. That was.
But Schirmer is normal for them.
Schirmer's was reduced in this patient, but when we compared it with the normal subjects, it was not found to be significant. Significance was more than 0.05.
Schirmer 2, but how did you do?
Schirmer's 2, that is with anesthetic.
With anesthesia. That means you are finding out what?
That is, we are finding the reflex secretion is discarded. That is, basal secretion was gone.
Basal secretion are produced by?
And that is accessory lacrimal glands.
Supplied by which nerve?
That is by the.
Don't take. You know you will not know. They do not have any reflex nerves. Please remember, no nerve supply.
Okay.
Understand now? They are all by sympathetic. That's all. We don't have a proper nerve supply. That's why they are called basic excretors. Okay.
How do you make a diagnosis of hypothyroidism?
Hypothyroidism. That TSH, based on the TSH value, here we take.
A simple test.
Simple.
Clinically, how do you suspect?
Hypothyroidism. That swelling.
Any intolerance to cold?
Intolerance.
Okay.
Thanks.
Next is Dr. Shirin, free paper 79.
Good afternoon. I'm going to discuss on the therapeutic efficacy of online dichoptic digital program in anisometropic and emetropic amblyopia. Amblyopia is a visual developmental disorder consisting of reduced best corrected visual acuity in one or rarely in both eyes without the presence of any ocular pathology. Usually it is accompanied by binocular dysfunction including nil or impaired stereoacuity and interocular suppression. Why is treating amblyopia important? As already discussed, it causes binocular vision impairment, it causes fixation instability and abnormal binocular interactions. Also, it has a substantial impact on the visuomotor task, difficulty in playing sports in children, locomotor safety in adults, and also it may limit career option for the amblyopes. And the abnormal cortical changes produced in amblyopia, it can be reversed if prompt treatment is instituted. Usually we say during the critical period, it continues till the 7 years of age, but after this age also the cortical plasticity is decreased, but it is never lost. So we can, this is the basis of interest in treatment of the management of adult amblyopia. And the conventional measures of management of amblyopia used are glasses, patching, we can use atropine drops for penalization, and new approaches based on the binocular origin of amblyopia has received considerable research interest. Dichoptic training. Dichoptic training, in this, each eye receives different stimulus separately and simultaneously, and to complete a task, both eyes are forced to work together. Here contrast adjusted images are given. The better eye receives image with less contrast and the amblyopic eye receive image with strong contrast. Binocs is a cloud-based software using the dichoptic principle used for the diagnosis and management of amblyopia. It can also be used as a telehealth vision therapy program. Aim of our study was to evaluate the efficacy of dichoptic therapy in the management of refractive amblyopia, and the objective was to study the improvement in visual acuity after therapy and to study the improvement in binocular functions after therapy. Inclusion criteria, we included subjects with refractive amblyopia of age 6 to 25 years in whom other methods of treatment of amblyopia has failed, and the exclusion criteria were amblyopia due to other causes, previous intraocular surgery, developmental anomaly, developmental delay, high myopia, deviation more than 10 prisms. And we included 16 participants over a period of 6 months. It was an observational study done at Contrast Eye Hospital, Calicut. Detailed history examination was done. Best corrected visual acuity, cycloplegic refraction, prism bar cover test, stereopsis and binocular single vision were assessed and recorded. Foveal fixation was ensured, and before starting therapy, we ensured that the participant get full cycloplegic correction, and if any deviation was present, it was corrected with prism in spectacle, less than 10 prism diopter. And our participants, the refractive error seen among our participants included compound hypermetropic and myopic astigmatism, simple hypermetropic, simple myopic astigmatism, and 3 of our participants needed prism in spectacles. Diagnostics can also be done with the Binocs software, and dichoptic therapy was done with Binocs Amblygo program. We gave sessions of training of 40 minutes daily, 5 days per week for 6 weeks. And that included a total of 30 sessions, and we used red-green goggles for dissociation, and the games given were Super Ball, Superman, Supercar and Super B. Assessment was done at 2 weeks, 4 weeks and 6 weeks after starting therapy, and a follow-up was done at 3 months post-therapy. BCVS, stereopsis and binocular single vision were recorded. Results: out of 16 participants, 13 were in the pediatric age group, that is less than 12 years, and 3 were in the adult age group. 14 of them were having an isometropic amblyopia and 2 of them were having ametropic amblyopia. Regarding improvement in visual acuity, all of our participants showed improvement in visual acuity. The pre-therapy visual acuity was 0.346 logmar, and the post-therapy at 6 weeks it was 0.159 logmar, and it was maintained in 3 months. And the paired t-test show statistically significant improvement in visual acuity. And improvement in stereopsis, that there was a statistically significant improvement in stereopsis also, but in our study those participants who had nil stereopsis pre-therapy had no improvement in stereopsis post-therapy. It was assessed with the Wilcoxon-Saint rank test. And improvement in visual acuity was seen among pediatric and adult age group, and also among anisometropic and ametropic amblyopes. And improvement in visual acuity was seen among all types of refractive errors we included, and in those whom we used prism and those in whom do not use prism. And to conclude, dichoptic therapy with Binocs is an evolving treatment in the management of refractive amblyopia. In our study we got good results in both pediatric and adult age groups. So we have to recommend this to more patients with refractive amblyopia. Limitations were sample size of a study was small and long-term follow-up after 3 months is not available to assess. And also, since the immediate treatment cost was high, many of the subjects were not willing due to financial problems, and many found it difficult to have a stable internet connection and a computer or laptop at home, as therapy has to be done online. Thank you.
Define amblyopia.
Amblyopia is a visual developmental disorder. Either it can be monocular or it can be present in one or both eyes without any organic cause.
Dr. Sumaya Muhammad Ali, free paper 86.
Good afternoon. My study is a comparative study of clinical profile of refractive errors in preterm and full-term children. Normal retinal vascular development usually begins as early as 16 weeks of gestation, which remains incomplete until term, that is around 40 weeks. So in premature delivery, that is in preterm, where retina is still in the process of development, with exposure to additional risk factors including oxygen therapy and NICU interventions, there occur retinal vascular ischemia, hypoxia and hypoplasia, which all leads to abnormal retinal development. This is simply the pathophysiology of retinopathy of prematurity, which is a leading cause of childhood blindness. With increasing survival rate of preterm, there is an increasing prevalence of ROP. Early screening and timely treatment of ROP are critical. Whether it is preterm or term, children need regular ocular evaluation to detect refractive errors early, because long-term visual outcomes are affected by the refractive errors. In our study, we are exploring the relationship between preterm birth, ROP and refractive errors, comparing the refractive status between preterm and term children. We conducted a retrospective analysis of 500 children, that is 250 preterm and 250 term, over a period of 6 years at our institute. We assessed the presence and severity of ROP by fundus examination, and we evaluated the refractive errors by cyclopegic refraction, and we recorded the findings every 6 months. So the result. So in preterm and term babies, 70% of babies found, in preterm babies, 70% of babies found to have refractive errors at 6 months, and in term babies, 35% of babies found to have refractive errors. We advised observation for both this group. This is the refractive profile obtained at 6 months of age in the study population. Considering the fact that children are typically hyperopic at birth, overall, the preterm babies have higher prevalence of refractive errors like myopia and astigmatism than the term children. So this shows the treatment approach among preterm and term babies at 6 months, 1 year and 5 years of age. At 6 months, we advised observation. At 1 year, in preterm babies, 15 out of 250, that is 6% needed glasses, and in 5 years, 98, that is 39.2% required glasses by the age of 5 years in preterm babies, whereas in term babies, 25 out of 250, that is 10% required glasses by the age of 5 years. This shows refractive correction needed among the preterm and term babies at 1 and 5 years of age. This shows there is a progression at 5 years of age. How the impact of ROP on refractive errors? In our study, out of 250, 54 babies were diagnosed with the ROP, and out of these 54 babies, 40 recur refractive error correction at the age of 5 years. This table shows the refractive error correction based on the treatment status. Out of 54 ROP babies, 10 who underwent non-treatment and 44 who underwent treatment. Out of 10 who underwent no treatment, 4 recurs refractive error correction by the age of 5 years, and out of 44 who underwent treatment, 36 recur refractive error correction. This ROP babies recur refractive correction based on the treatment type. So in out of 10 ROP babies who underwent no refractive correction, 4 recur refractive corrections. Out of 34 post-laser treatment ROP babies, 28 needed glasses, whereas out of 10 post-injection babies, 8 requires glasses. This shows how the severity of ROP, how the severity of refractive errors increases with the severity of ROP. Coming into discussion, there are various studies. In the study 2015 by McDonald et al., there is ROP and prematurity contribute to increased incidence of refractive errors in children, and in 2017 study, preterm children, especially those with the ROP, have higher prevalence of myopia. And in 2006 O'Connell et al. Study, preterm infants show higher rates of refractive errors at school age with the refractive measures needed. In our study, we also found out that there is increased prevalence of refractive errors in preterm babies than term babies, and there is also higher risk of refractive errors in infants with ROP, and risk increases with the severity of ROP. There is also persistence and progression of refractive errors noted. That is 6% needed glasses by the age of 1 year in preterm, which progressed to 39.2 by the age of 5 years. Refractive errors tend to persist and worsen over time. In full-time babies, there is lower and less progressive prevalence of refractive errors noted. There is also the role of gestational age and birth weight, because more premature and lower birth weight infants have already at a higher risk of developing ROP, so as refractive errors. KSOS test is used for the comparison of refractive errors between term and preterm babies. We get a p-value of less than 0.05, which indicates its statistical significance. So preterm infants have a significantly higher prevalence of refractive errors, and preterm birth and ROP increases the risk of refractive errors. So in conclusion, our study strongly emphasizes that preterm birth ROP, there is a strong link between preterm birth and ROP, and higher prevalence of refractive errors in preterm than ROP. Many studies which solely focus on the refractive errors in babies with the ROP, whereas our study compares refractive errors in preterm babies, whether they have ROP or not they have ROP, with those in full-time babies. This provides a broader view of the impact of prematurity on refractive errors. So in conclusion, whether it's a preterm or term, all babies need yearly and routine eye examination, with the preterm babies requiring closer follow-up and regular reviews due to their higher risk of refractive errors. These are my references. Thank you.
These preterm babies were given ROP, with ROP, were given treatment or not?
Yes, sir. 50 out of, in our study there are 250 preterm babies. 54 were diagnosed with ROP. Out of this 54, 44 underwent treatment. There is 38 who underwent injection, laser treatment, and 10 underwent
Those
injection treatment.
treated patients had a, what type of staging, grade? Stage 1 or 2?
Stage 2 and stage 2, 3 and 4, sir.
4?
Retina.
Stage 4?
Stage 3.
Normally, metropization occurs at what age?
In preschool, 3 years.
Why do you prefer cycloplegic refraction children?
To know the correct refractive errors, to paralyze the ciliary muscle, we can block the accommodation.
How much accommodation in children? Total, even up to 6 to 8 they have first.
Thank you.
Dr. Aisha Sana.
A very good afternoon, dear all. I am here to present my research work on barriers to screening for diabetic retinopathy among diabetic patients attending a tertiary care center in Kerala. So, diabetic retinopathy is the leading cause of blindness and visual impairment after cataract and uncorrected refractive error in India, and the prevalence was found to be around 16.9%, with the prevalence of sight-threatening diabetic retinopathy 3.6% and that of mild retinopathy 11.8%. So, the causes of decreased vision include diabetic macular edema, macular ischemia, sequelae from retinal ischemia like retinal neovascularization, vitreous hemorrhage, retinal detachment, tractional retinal detachment, neovascular glaucoma, etc. So the significance of diabetic retinopathy screening is that the visual loss or impairment due to diabetic retinopathy can be delayed by early detection, timely intervention in the form of prompt treatment. So on reviewing a few literature, it was found that a large proportion of the patients had sight-threatening diabetic retinopathy at presentation, and the significant risk factors for delayed presentation include lack of knowledge, patients being asymptomatic, lack of bystanders, and cost, etc. So there is this a lacunae of studies on barriers for screening diabetic retinopathy in this part of the Kerala, and hence the need for this study. Moreover, it is important to look why patients present late with sight-threatening diabetic retinopathy. So the primary outcome of the study is to find out barriers to screening for diabetic retinopathy in patients with diabetes mellitus, and secondarily to compare those barriers based on patients' response. So this is a cross-sectional study conducted in patients with history of diabetes mellitus attending the ophthalmology department of a tertiary eye care center, and patients of age more than or equal to 18 years were included, and they were interviewed using a pre-tested semi-structured questionnaire with consent. So this was a 6-month duration study conducted in 150 patients, and the barriers considered in this study include fear, lack of knowledge, felt it was unnecessary as no symptoms, transportation difficulties, inability to find time, no bystander, cost, difficulty in getting appointment, difficulty in doctor-patient interaction, tedious nature of follow-up due to other systemic illness, etc. So this is the questionnaire I have supplied to the patient, and it has details regarding demographic data, diabetes related questions like its control, other comorbidities, and few questions regarding the knowledge about diabetic retinopathy. So this is a barrier related question, as I have asked the patient to rate them on a 5-point scale from not at all important to extremely important. So I included the patients with both type 1 and type 2 diabetes with age more than or equal to 18 years, and those consented to participate in the study, and those with first visit to our hospital. Patients not able to respond to the questionnaire were excluded, and we found that majority of the patients were males and the mean age was 59 years. It was mostly type 2 diabetic patients, and most of them were well controlled. Complications was in minority of the patients like neuropathy, nephropathy, and most of the patients on oral hypoglycemic agents. So the primary outcome was found to be lack of knowledge, which was seen in around 66% of the patients, followed by absence of symptoms in around 56%. So among the patients who were aware of diabetic retinopathy, we found that lack of time or inability to find time for screening was found to be the most important barrier, followed by lack of bystanders and cost in the order. So we classified the study population into 3 groups: those with no diabetic retinopathy, those with non-sight-threatening diabetic retinopathy, and those with sight-threatening diabetic retinopathy. And lack of knowledge was found to be the most important barrier among all the 3. So the study highlights barriers in diabetic retinopathy screening in our area, which lead to delayed presentation of diabetic retinopathy. And knowing these barriers is important to plan strategies to overcome those barriers. So on review of few literature, it was found that Indian studies mainly showed lack of knowledge as the most important barrier, whereas foreign studies showed that too many appointments, cost, transportation, language issues were the important barrier. Finally, our studies conclude that lack of knowledge was found to be the important barrier, followed by absence of symptoms, inability to find time, and lack of bystander, cost, transportation, fear, etc. in the order. So the limitation is that this was a small sample size and the questionnaire may be better distributed in a diabetic clinic. So I conclude that the information obtained is important to implement strategies to increase the awareness of diabetic retinopathy and overcome those barriers at primary healthcare level so that delayed presentation of diabetic retinopathy can be prevented. I recommend physician or diabetologist should be informed about diabetic retinopathy screening, patient counseling regarding regular screening, community-based outreach programs utilizing digital tools, artificial intelligence apps, and social media, providing more flexible screening options, and providing financial incentives or coverage for screening. Thank you. Thanks.
Next is Dr. Brinda K. Free paper 105.
Good afternoon, everyone. My paper is on Elog Atlas, a timeless reflection of PG life. Logbooks are integral part of PG residency because it helps in structured learning and documentation of clinical as well as surgical milestone. It encourages our responsibility, and it helps a PG resident to self reflection, how much we have to improve, etc. And it improve our professionalism, and it can be used for an evidence for certification and portfolio for future exams. And for a mentor, it can be used as a tool to assess how much their mentee is improving, and it ensures competency in PG life. For years, we have been using written logbook, but using written logbooks has legibility issues, and it is prone for human errors. There is risk of loss, misplacement, etc. because due to lack of backup, and storage is also limited with the written logbook, and there is no option of search. Hence, that will be difficult to search for a case in a written logbook, and it is inconvenient to update because it became messy, and there is limitation of maintaining a high quality image with the written logbook. And to share a written logbook, we have to present physically, and there is lack of integration. Ophthalmology heavily relies on the visual diagnostic, so for a PG resident, it is very crucial to remember the image and interpret the image in developing strong diagnostic skills and clinical decision making. So that is how we attempted to revamp the traditional logbook approach by encompassing clinical photograph with a concise summary of interesting cases we come across in OPD as well as community outreach program. For that, we collected images in OPD as well as camps for in 10 months of our first year residency. Earlier, we used to take pictures with our smartphone, and we used to collect even series of images on their follow-up visit also. Later, once we were used to the slit lamp, we used to collect the images we taken with the slit lamp, which is attached to the imaging system. And with the slit lamp not attached with the imaging system, or especially in the peripheral centers, we used the simple smartphone adapter and attached it to the slit lamp and taken the anterior segment as well as posterior segment images. We even used it to take microscopic images also. For fundus images, we collected images from our fundus imaging system in the hospital. And for community outreach programs, we used 3D printed anterior segment photo imaging system for the anterior segment photo images. And for fundus images, we used 3D printed posterior segment imaging system as well as smartphone based portable fundus cameras. And later on, with the images, we used to discuss with our consultant, and we documented the same image along with a short summary into simple digital platforms like Microsoft PowerPoint. After discussion, we used to add the annotation to make it more useful, and I would like to show you few pages of our eLog atlas we have created. And later on progress, we used to collect images even from the OT, and we used to contact with our lab associated with, and we used to get the pathological pictures also and add the annotation with the pathological images also. Later on, we divided the images we have collected into anterior segment as well as the posterior segment. And so changing from a written logbook to e-logbook, it was very efficient for data entry, and the fields were customizable, and there was an option for automatic backup search. Search option was also there, so it was easy to find any cases, and it was more flexible and easy to update. For sharing and remote access also, it was easy. Multimedia integration was possible. It improved our accuracy and standardized documentation. This is the e-logbook we follow. Adding images with the e-log, that is e-log atlas, has enhanced our visual learning compared to the written logbook. It encouraged our active learning and reflection, and the images helps to retain more than the text. So it improved our retention and recall. It enhanced learning and disease management. It has helped in collaborative learning among the PG residents, as we used to discuss about the images, and we used to share it in a WhatsApp group, the images as well as the summary, and it has helped us as a potential tool in preparing for OSCEs and Vivas, and we could able to integrate technology along with the e-log atlas, like the link of the surgery that we can share along with the atlas, and it has facilitated the objective assessment and feedback. And to conclude, e-log atlas stands as a cherished timeless reflection of our postgraduate life. Hence, it will be useful to consider it as an essential tool in postgraduate residency. These are my references. Thank you.
Very nice presentation, but these are all stored in your laptop.
Sir. And we share it in Google Drive also.
That's okay. Suppose it gets these are all vital informations. Can they get affected by virus problem of the laptop and all? Will virus will affect these problems or not? These studies. We are saving so many pictures, you know. Can they be affected by virus?
Till now, it has not, sir. We used to share it in Google Drive.
Suppose it gets affected with virus, means you are going to lose. Suppose book means you can have permanently will have no.
Yes, sir. But we share daily, so that if 4 of residents are there,
you are saving, man. You are sharing, yes, but by chance you are losing everything.
It will be in the drive, no, sir. So we can take from another system.
Oh.
If one system get a virus, we can. It's in drive, so we can log in with another system and it will be.
Okay. Okay. Thank you. Nice.
Thank
you.
Sir.
Next we have Dr. Julie Anthony, who will be talking on gimbal scope, smart trail, smartphone assisted retinoscopy trial.
Good afternoon to all. My topic of presentation is gimbal scope, smart trial, smartphone assisted retinoscopy trial. So as we all know, retinoscopy is an objective method of assessing refractive error. So it is a skill dependent technique and there is no live demonstration can be done. So as a resident in the initial phase of learning, it is very difficult for as a resident to understand the art of retinoscopy. So usually the mentor teaches the trainee with the help of a schematic or model eye and there is no video library of reflexes available. So usually the mentor teaches the trainee with the help of schematic model to make them understand about the reflexes. This is a schematic model showing the with the movement reflex, and next is a against the movement reflex. So it is very difficult for a trainee to understand the retinoscopy reflexes. So that's how the thought of making a gimbal scope, that is attaching a smartphone to a gimbal. Gimbal is an object that helps in act as a supporting system, and we attach the retinoscope to it. So this is the final look of the gimbal scope. The materials needed for the for making the gimbal scope are any smartphone or Android phone, 3 smartphone adapters. The adapters can be attached using a simple rubber band or super glue, and the retinoscope. So this is the video showing how to make the gimbal scope. We attach the adapters with a screw and attach the retinoscope in the adapter. Then the mobile phone is attached to the adapters, and the mobile phone camera should be aligned with the peak hole of the retinoscope. So this is the video we recorded using the gimbal scope showing the with the movement reflex. Both the trainer and the trainee can see in the real time. This is the recording showing the against the movement. This is the neutralization point. We have also recorded the scissoring reflex in a keratoconus patient. So the objectives of our study are to evaluate the precision and dependability of smartphone-based retinoscopic reflexes and measurements compared to streak retinoscopy and autorefractometer. And we have also compared the quality and lucidity of the retinoscopy reflexes, time taken and ease of doing. The sample size where we have done a prospective comparative study with 1000 patients. The mean age group was selected as 18 to 50 who presented at our hospital for ophthalmic evaluation. The study period was 8 months from November 2023 to June 2024. The methods, we assessed 1000 patients who presented at our hospital were randomly selected, and after proper written consent, each patient went through gold standard retinoscopy, smartphone based retinoscopy, and the respective values were recorded and compared with values obtained from autorefractometer. Both mydriatic and non-mydriatic values were taken, and spherical and cylindrical values were also obtained using all 3 devices. These are the results obtained. Out of the 1000 cases selected, there were 532 males and 468 females. And in both undilated and dilated, on comparing gimbal scope with streak retinoscopy, we have got out of 1000 we have got 823 patients with same values, and in dilated patients also out of 1000 we got 858 patients we got similar values. In comparing gimbal scope with autorefractometer, in undilated out of 1000 patients 816 had similar values, and comparing in dilated out of 1000 we got 874 patients got similar values. So we have taken the accuracy and confidence interval. So in both the cases undilated and dilated, comparing gimbal scope with streak as well as autorefractometer, we have got accuracy more than 80% for all. So conclusion, smartphone based retinoscopy yields refractive error measurements comparable to standard retinoscopy and autorefractometer with no statistically significant difference. It demonstrated feasibility in assessing refractive error, providing accurate and precise results while minimizing time and discomfort. So we conclude that gimbal scope is a very efficient teaching tool. You can do it by yourself and it is very economical and cheap, and you can also do live demonstration. You can also record and document the reflexes and use it for future discussions or presentations, and it is an affordable toolkit for postgraduates. As any tool, our gimbal scope has limitations. There is an initial learning curve, then it is a little bit heavy. There are minor differences in the measurements. There is a difficulty in accessing the focusing sleeve. These are my references. Thank you.
You get gimbal scope from where? You prepared?
No, actually my mentor.
You prepared?
My mentor prepared. We have done the study.
Actually, what is the purpose of using gimbal?
More of a teaching tool.
Apart from teaching, in photography, videography.
No, with that we can also assess refractive errors. Prescription of glasses.
Not a photographer used gimbal for what?
As a support for better rotation of camera.
Smooth movement, with a vibration, we can avoid vibration. Okay.
Thanks.
Yeah. Next we have Dr. Henna Abubakar, who will be talking on SSOCT evaluation of anterior segment and occludable angles, topical pilocarpine versus laser iridotomy.
Good afternoon. My study is on SWEPSO-OCT evaluation of the anterior segment in occludable angles, topical pilocarpine versus laser iridotomy. There is a huge burden of primary angle closure glaucoma in Asia. So there is a need to detect this disease spectrum at the stage of primary angle closure suspects. It's known that gonioscopy is the gold standard for detection of narrow angles, but it is subjective and needs more expertise. Imaging modalities with the advent of newer SWEPSOs ASOCTs acquire high resolution images of the angles with a relatively shorter acquisition time, and it's more objective. Previously, pilocarpine has been used for narrow angles, for treatment of narrow angles, but nowadays laser iridotomy is the standard of care. So the aim of our study is to assess and compare changes in the iridocorneal angles after pilocarpine instillation and laser iridotomy in primary angle closure suspects using SSOCT anterior. Ours is a prospective observational study conducted in 50 occludable angle patients conducted over a period of 1.5 years.
Subjects more than 40 years were included in our study, and those with secondary angle closure and corneal pathologies were excluded. PACS recruited after 4-mirror gonioscopy by a single examiner, and 3 anterior segment OCTs were taken. Firstly, at baseline when the patient comes for laser PI, second after 30 minutes of pilocarpine administration, and the third after 1 week of laser iridotomy when the patient comes for review, and these 3 measurements were compared. This is the anterior cross-sectional image of the angle. All the angle measurements were dependent on the accurate manual positioning of 2 parameters, 2 points, the angle recess point, which is shown in red, and the scleral spur shown in yellow. And the measurements were taken at 500 and 750 microns from the scleral spur, as shown in the right side. The angle parameters taken were anterior chamber angle or ACA, trabecular iris space area or TISA, angle opening distance or AOD, and scleral spur angle SSA. These were measured at 500 and 750 microns from the scleral spur in both the nasal and temporal quadrant, hence a total of 16 angle parameters. Besides this, anterior chamber and lens parameters were anterior chamber depth, volume, lens wall, and lens thickness. Coming to the results, in our study majority were females, and this table shows all the 16 angle parameters on the left hand side, and P1 showing the significance of the angle width improvement baseline versus post pilocarpine, and P2 the significance of improvement post laser PI, and it is seen that a widening of all the angle parameters post laser was seen as seen in the right hand side, and significant widening of most of the parameters except 3 parameters for after pilocarpine installation. So it's seen that laser iridotomy widens the angles better than pilocarpine. The most significant angle improvement was seen with anterior chamber angle in the nasal and temporal quadrants, which was followed by angle opening distance. The same is shown in this box and whisker plot of anterior chamber angle widening. There was progressive widening post pilocarpine and post laser. And this slide shows that pilocarpine reduced the mean AC depth and volume, while laser increased the anterior chamber depth and volume. And lens wall significantly increased post pilocarpine and decreased post LPI. Coming to discussion, post pilocarpine AC depth decreased in our study and lens wall increased, which was supported by Rachel et al. And post laser AC depth and volume changes were supported by Zebardast et al. Meduri et al. Was the only study seen done in occludable angles using anterior as done in our study, but our study had more sample size, and in both the studies in the temporal quadrant there was statistically significant widening of the angle measurements post laser, and but in the temporal quadrant maximum improvement was seen with anterior chamber angle in our study, and whereas with trabecular iris space area in their study. And this is showing other similar studies using different ASOCT machines and showing the angle width improvement. And Rachel et al. Showed the effects post pilocarpine and laser PI in narrow angles and showed greater widening post laser than post pilocarpine. Coming to conclusion, laser PI is very effective in widening the iridocorneal angles in primary ankylosing suspects as assessed with anterior, and the greatest widening was noted with anterior chamber angle and angle opening distance. Pilocarpine also significantly improves the angle width, but to a lesser extent than laser iridotomy. My references. Thank you.
What is the mechanism of action of pilocarpine?
Pilocarpine stretches the root of the iris so that it opens the angle and helps in drainage of the aqueous.
Yeah, next is the last talk of the session. That is by Dr. Lakshmi Parvati, and she'll be talking on association between severity of diabetic retinopathy and urine albumin creatinine ratio in type 2 diabetic mellitus.
UPS 6 minutes. UPS 6 minutes last.
Slide show നാക്കി തരൂ. Slide show നാക്കി. Good afternoon. My topic of presentation is association between severity of diabetinopathy and urine albumin creatinine ratio in type 2 diabetes mellitus. The prevalence of diabetes in India is 101 million, and type 2 diabetes form more than 90% of the total cases. Microvascular complications may develop in 30% of the cases in type 2 diabetes. Generally, patients with diabetinopathy receive medical attention earlier than those with diabetic kidney disease. DKD is now the leading cause of end-stage renal disease worldwide and causes significant morbidity and mortality. Even though KDIGO guidelines suggest that the renal biopsy is an acceptable diagnostic test for managing renal diseases, performing it for the early diagnosis of asymptomatic DKD is impractical. In clinical practice, urinalysis for albumin creatinine ratio is the usual method for diagnosing early stage renal involvement. Studies have reported that diagnosis of one microvascular complication indicates a high likelihood of developing others. However, only a few studies have investigated the association between severity of diabetinopathy and ACR in patients with type 2 diabetes. So, this aspect is explored in my study. So, my research question is an association between severity of diabetinopathy and urine albumin creatinine ratio in type 2 diabetic patients. Objective of my study was to determine the association between severity of diabetinopathy and urine albumin creatinine ratio in type 2 diabetic patients. So it's an observational cross-section study conducted in the Department of Ophthalmology of our institution from 4/11/22 for a period of 12 months from the date of ethical committee clearance. Study population included all type 2 diabetic patients with diabetinopathy who attended the Department of Ophthalmology of our institution during the study period. Sample size was calculated by the formula Z square PQ by D square with a margin of error 20% based on a study conducted by Saini et al. In 2019 at Rajasthan. Sample size was calculated as 178, which is rounded to 180. So, based on the inclusion and exclusion criteria, 180 participants were recruited from the study population. Inclusion criteria was all type 2 diabetic patients above 40 years of age with diabetinopathy who belonged to study population and who had given valid informed consent for the study. Exclusion criteria was those with pre-existing pathologies causing media opacities that obscure the fundus view, patients with macular edema from causes other than diabetes, and patients who received an individual injection. So from every participant, detailed medical and ocular history were collected, BCV and IOP were recorded, slit lamp examination of the anterior segment and fundus examination using indirect ophthalmoscope and 90D lens was done, and severity of diabetinopathy was created by ETDR's classification. Relevant investigations and urinalysis was done for albuminuria and UACR, and diabetic kidney disease was classified as per the KDIGO guidelines. KDIGO category A1, that is UACR less than 30 mg per gram, A2 between 30 to 300 mg per gram, and A3 more than 300 mg per gram. This collected data were recorded under Microsoft Excel spreadsheet and analyzed using SPSS version 23. Association between severity of diabetinopathy and UACR was determined by chi-square test or Fisher exact test, and the level of statistical significance was set up at a p-value of less than 0.05. Coming to observation, majority of the participants belong to 6th decade, that is 43.9%. Majority of the participants were males, 54.4%. Majority of the participants present with blurred vision as their presenting symptom. Majority had diabetes for a period of 10 to 19 years, and all participants were taking either insulin or OHA for their treatment, and 40% were taking both insulin and OHA. Majority had hypertension as a commonest comorbidity followed by dyslipidemia. Hematological examination revealed anemia in 43.3% of the cases. HbA1c was highly elevated in 64.4% of the participants. Elevated blood urea and serum creatinine was seen in 26.1%, and albuminuria was seen in 77 participants. Abnormal UACR was seen in 81.1%. Coming to ophthalmic examination finding, best corrected visual acuity was affected to a variable degree in both eyes. Majority had visual acuity in the range of 66 to 680. IOP was normal in all participants, and NVI was present in one participant.
Coming to distribution of ETDR's category of diabetinopathy. Diabetinopathy affected both eyes, so study participant to 18 degrees, and the grade of diabetinopathy in severely affected eye was considered for statistical analysis. Of the 180 participants, 92 had NPDR, 88 had PDR. Among NPDR, 1 participant had mild NPDR, 50 had moderate NPDR, 41 had severe NPDR, and 88 had PDR. 85 participants had clinically significant macular edema. The mild NPDR case was free of CSME. 38.8% moderate NPDR, 42.4% of the severe NPDR had CSME. In PDR, 16 had CSME. Coming to distribution of severity of UACR, majority belong to KDIGO category A2, that is UACR between 30 to 300 mg per gram. In this study, there was one participant with mild NPDR who belonged to KDIGO category A1. Among moderate NPDR, majority belong to KDIGO category A2, that is 46%, followed by KDIGO A1, that is 28%. In severe NPDR, majority belong to KDIGO category A2, that is 39%, followed by A3, 34.1%. Among PDR, majority belong to KDIGO category A3, 47.7%. According to Fisher exactors, there was a statistically significant association between severity of ETDR's category of diabetinopathy and severity of UACR with a p-value 0.006. On comparing my study with the parent study Saini et al. Coming to distribution of KDIGO category A3, it was same in both PDR and severe NPDR, whereas in my study it was more in PDR compared to severe NPDR. The distribution of severity of UACR was same in both the studies, that is KDIGO A2 followed by A1, A3, then A1. To summarize, in my study, majority was NPDR. Among NPDR, majority had moderate NPDR, followed by severe NPDR, and then mild NPDR. Elevated blood urea and sudden creatinine was seen in 26.1%, but abnormal UACR was detected in 81.1%. To conclude, urine ACR is a simple useful method to detect early renal involvement in patients with retinopathy. There is statistically significant association between severity of diabetinopathy and severity of UACR in type 2 diabetic patients. So, assessment of severity of diabetinopathy can be used as a screening tool for early detection of extenuating microvascular renal complication and its progression in type 2 diabetic patients. Sir, my reference. Thank you.
Thank you. Nice presentation, doctor. But you know, you have calculated sample size. Do you know the meaning of that? Because you have given so many formulas and all. You calculated or statistician calculated for you? You have understood the formula? You have understood? Sure. Okay. No questions, sir. Thank you very much. I think this completes 2 days free paper session on Dr. Subramaniam's medal. Tomorrow we'll have the finals. I hope all of you may be coming there. Thank you very much.